Dear colleagues, ladies and gentlemen, welcome to the view from the Thoraxcenter for Radcliffe Cardiology. This time we are previewing the late-breaking clinical trials at EuroPCR 2025. I am Nicolas from Mieghem. Next to me, my good friend and colleague, Joost Daemen. Joost, a lot to talk about, but it's a different kind of late-breaking trials as compared to, for instance, the American College or TCT or American Heart.
Well, absolutely. I mean, this year we got a list of 72 hotlines and late breakers that are going to be presented during the 4-day course. But what is basically what this is a little bit different meeting than the larger meetings like TCT, ACC, AHA, which perhaps are a bit more focused on the real science behind the clinical practice. But the unique aspect of this meeting is really the course-like aspect with a lot of training and education sessions by experts in the field. But that said, there are some interesting studies that are going to be presented and that we will briefly highlight for you to keep an eye on during the meeting, which will be held in 2 weeks in Paris.
Yeah, and a lot of ideas and innovations that are exchanged among peers. So let's start with the UK TAVI 5-year data. And this is a randomized controlled study that obviously was run in the UK. All the sites that were performing TAVI and surgery were involved in this trial, and patients were eligible if they were considered to be at moderate operative risk. So either they were 80 years old or older, or above 70 with comorbidities. This is a non-industry sponsored study, investigator initiated, and the mean age of the patients 81 years old, a total of 890 patients, almost 50% women. The STS and the Euroscore 2 were less than 3, so indeed low to intermediate operative risk patient phenotype. And we already know the results at 1 year. The death was numerically lower with TAVI as compared to surgery, and other complications were typically as distributed, what you can expect in these randomized comparisons. So you have more pacemakers with TAVI, so 14% versus 7%. But on the other side, more major bleeding, for instance, with surgery, 20% versus 7% with TAVI. Now we will get the results at 5 years, and I think this is an interesting 5-year follow-up because we already have the data from the Partner 3, from the Evolute Low Risk. So what is happening now? Is this consistent? Do we see at 5 years also no difference between the two treatment strategies? Or do we see some catching up between surgery and TAVI? Interesting data, in my opinion. The only caveat here is that the mean age of the patients was 81 years old. So you would expect significant mortality at 5 years in the two treatment strategies. But, let's see.
Let's see.
Yeah, and maybe also to remind you that a similar initiative was done in Germany, larger trial, 1,400 patients, a little bit lower risk. STS score was 1.8, mean age was 74 years old. We don't have the 5-year follow-up data of that trial for now, so only 1-year data available there. So this is also another trial to keep an eye on in future meetings. Okay, we also have the randomized comparison between two balloon expandable platforms, the Mieghem versus Sapien. That was the COMPARE TAVI randomized controlled study that was run in Denmark in 3 sites, more than 1,000 patients, mean age of 81, 40% were women. And also there, the 1-year outcome was published in the Lancet last year. And there was no difference between the two treatment strategies, but there was more moderate PVL with Mieghem, also more pacemakers, 19% versus 10% with Mieghem. On the flip side, mean gradients were higher with a Sapien valve as compared to the Mieghem. Question here is, what happens at 3 years? Do we see more hospitalizations? Are there more events whatsoever with one device over the other? I think an interesting study, well suited for EuroPCR. Also, the ACURATE IDE trial, Joost, we discussed this trial at TCT. The trial was presented there, and the big news was that the ACURATE platform did not meet non-inferiority as compared to commercially available valves. And there was this potential hypothesis that there was too much underexpansion in the ACURATE arm. As a matter of fact, more than 1 in 5 of the patients experienced underexpansion of the ACURATE valve. And there were all kinds of explanations given, but no deep dive. And we will get the deep dive now at the EuroPCR. I think Raj Makar is going to present this. And we'll also learn how underexpansion may or may not affect thromboembolic events and mortality in the months following a TAVI procedure. So looking forward to the results, and also wondering whether we will get some published data here.
Yeah.
Have you seen some
No,
data
I
there?
have not, and I think this is the obviously the important question that is still, let's say, surrounding this trial in a way that, I mean, these results were a little bit unanticipated. In a way that, I mean, the endpoints, all of the individual endpoints in the trial actually were favoring the control device. In a trial now that showed that perhaps everything was due to underexpansion, I don't know. But let's see what this deep dive will show, and then hopefully we'll get the findings published soon.
And then maybe one of the most anticipated trials or presentations will be the pooled analysis on the Sentinel cerebral embolic protection. We have 2 randomized controlled trials, and if you combine the two, 1,200 patients that were 1-to-1 randomized to either TAVI with a Sentinel filter-based embolic protection or TAVI without cerebral embolic protection. Each trial by itself showed no difference and no treatment effect basically with the use of the Sentinel, although in the protected TAVR there was a reduction in disabling stroke in favor of use of Sentinel embolic protection. Let's see how this pooled analysis will shed new light on this topic. But obviously, if in 12,000 patients we don't see
12,000, right?
Yeah,
Not 1,200.
Yeah, 12,000. If we don't see an effect on this hard clinical endpoint of stroke, then yeah, we might need to revisit the use of cerebral embolic protection. And we discussed it already in previous wrap-ups and previews of meetings. My belief is that we may need to find a more appropriate endpoint. Maybe stroke is not the neurological endpoint that is needed, and maybe we need to try and focus more on neurocognitive functioning, personality disorders or changes, that kind of subtle changes that you might have that you might see after structural heart interventions, and that may become very relevant if we start to treat younger patients.
Yeah, that is true. That said, my only hope is that this now larger patient population may help to find, let's say, some more hints into directions of categories of patients that potentially may benefit more as compared to others. But again, as you say, both trials were negative. So I'm not sure, but that's something that at least could pop up within this pooled analysis with a larger sample size.
Yeah, there's also a trial that is looking into the value or the significance or the meaning of coronary physiology in the context of patients undergoing TAVI. What is that?
Yeah, so Flavio Ribiccini will present the FAITAVI trial, which is basically an Italian randomized controlled trial that will assess the value of physiology-guided PCI, or revascularization, I should say, versus a angio-guided revascularization approach in a total of about 300 patients with severe aortic stenosis. Conceptually interesting because, as you know, there's been a lot of debate in patients with intermediate coronary artery lesions that undergo physiology-guided assessment in the setting of severe aortic stenosis, which basically may underestimate the severity of the lesion by using hyperemic indices. So in that perspective, Ribiccini and colleagues did some efforts in building quite an extensive physiology algorithm in which the physiology had to be determined upfront in the FFR arm. However, also had to be repeated after the TAVI to compare changes in physiology. But to make things even more complex, patients in which the physiology is negative or borderline also had in those also the physiology had to be repeated after the TAVI, which could change the likelihood of getting a revascularization. There are basically 3 time points that the patient may get its physiology assessment. I think the interpretation of the results will be a little bit difficult, but let's see how they will present the data. and see whether the addition of physiology in this typically elderly patient population that will likely experience most of the benefit by the TAVI itself will make any difference in terms of
So help me understand. So the repeat assessment could be done during the index procedure or later?
At least after the TAVI. So baseline in the physiology arm, baseline assessment, hyperemic and non-hyperemic indices, hyperemic index FFR will be used for clinical decision making. In case the physiology is either negative or borderline, somewhere between 76 and 83 if I'm correct, then the physiology needs to be repeated directly after the TAVI and then may change the treatment decision as to whether to go for PCI or not. At least that's what I understood from the protocol.
Well, what also is of interest is which platforms are they using, right? A tall frame, short frame, that might also affect the success rate of recanalizing or getting access to the coronaries. So
let's see.
Yeah, let's see. And that's a nice switch to the coronary space.
Yeah, more on physiology will be presented by Tim van der Hoef, our colleague from Amsterdam, initially now working in Utrecht, who, when he was still in Amsterdam, actually developed the ILIAS ANOCA trial. So ILIAS is the coronary function testing program that the people from AMC have been pioneering in the past decade, I think. Now they developed or designed a randomized control trial focusing on patients with ANOCA, which underwent extensive coronary function testing, including microvascular resistance, flow testing, and spasm testing if needed. All of them. And then they were randomized to either unblinding of the results and applying a tailored treatment approach, for instance, being more aggressive with calcium antagonists or nitrates, versus coronary function testing that was blinded to the physician and the patient, him or herself. With the primary endpoint in this trial being the SAQ score at 6 months. So 150 patients, 1-to-1 randomized, blinded CFT testing versus unblinded CFT testing. Conceptually, I think a hot topic. There's a lot of focus on coronary function testing, which makes sense if you consider that 30 to 50% of our patients in the cath lab with stable angina appear to have ANOCA. So that makes the concept of doing more extensive testing quite interesting. Whether this specific testing in the absence of validated treatment option will really help in improving Seattle angina scores at 6 months, I'm not so sure. But at least an interesting trial that will shed some light on the meaning and the value of these extensive testing approaches in patients with ANOCA.
I think that is the main issue. What treatment algorithms can we offer to these patients? I mean, this is all empirical, not very scientific. But okay, it's interesting. It's a conceptual sort of trial.
Yeah, and I mean the endpoint is a soft endpoint. But conversely, if you tell somebody that his or her microcirculation is abnormal and the patient now finally has a diagnosis, that may give some symptom relief by itself. It's a very soft endpoint, but I mean that's the concept that has been advocated over the past decades. But let's see.
All right.
More on physiology from the CAREER trial, a sub-study presented by San Van Tu, who presented the CAREER trial, I think last year, a trial validating the accuracy of CT-derived physiology using the Pulse CT Plus software versus Angio FFR-guided CT as a referent. In this case, also focus on plaque characterization using the CT software and outcome. So this is not a validation study, but a, let's say, sub-study focusing on the prognostic value of the FFR CT and plaque characterization done by the same software in terms of outcome. So I think that is something to look out for, as this to me is a very hot topic in patients that are screened by CT scans.
Okay, next on calcific disease.
Calcific disease, the iCare OFDI trial would be presented. Also an interesting one, multi-center randomized controlled trial in France, 178 patients that will be randomized with calcific lesions to either IVL or rotablator treatment, and then subsequently treated by Ultimaster DES and assessed by the Terumo OCT, the OFDI, in terms of stent expansion. The trial was developed or designed as a non-inferiority design. I think it's interesting in the absence of proper comparative randomized controlled evidence with both technologies actually. Conversely, these, in my perspective, are technologies that should be seen as adjuncts and not so much as competing technologies.
Yeah, yeah. It's also in line with another trial that is currently ongoing in the lowlands in Belgium and the Netherlands. It's called SONAR.
Yep.
Johan Bennett from Leuven is running that trial, and it's also comparing intravascular lithotripsy with shockwave with rotablation. So this might be a teaser of SONAR, if you will.
Yeah.
Okay, then there is also the Retrieve AMI trial, and we go then into the context of STEMI, where it's a randomized controlled trial with 3 treatment arms, either PCI or PCI in combination with aspiration thrombectomy or PCI in combination with stent thrombectomy with a stent retriever. I think conceptually an interesting trial. The issue is obviously that we already know that systematic use of aspiration thrombectomy doesn't work in STEMI. I think something similar applies to the use of the stent retriever, but there are isolated cases where you want to have some kind of embolectomy device. And we encounter on a maybe not so regular basis, but from time to time cases where also aspiration thrombectomy just is not helping us. And we need more potent thrombectomy technology. And I think the experience from our neurology colleagues, the interventional neurologists or radiologists in the treatment of stroke can also be helpful in the coronary setting. So I'm looking forward to learning more of that technology. We are already using stent retrievers in our lab, but it's good to have some scientific backbone to bulk this up. So I'm interested in this result.
Yeah, me too. Interesting. The endpoint though is assessed by OCT. So the endpoint is OCT-derived thrombus burden, which is not really a validated endpoint. But we tried to do the same with IVUS in the Spectrum trial, published that last year. It is possible, but we developed with IVUS a specific IVUS-derived thrombus score. Things like this do not really exist, so I'm curious to see how the investigators will solve that.
And then obviously safety, yeah.
Absolutely.
How is the safety of these stent retrievers? Okay, let's go back in the past.
Yeah, so back in the past, very short, brief overview. There's a lot of, typically in PCR, there's a lot of long-term data that is presented, and also within the stent field, which is perhaps not the most catchy field for most of the interventionalists these days, but there are a couple of trials that will present a long-term follow-up that could be of interest. One is the 7-year results of Compare Absorb. As you recall, the randomized controlled trial comparing the Abbott BVS versus a Zyne stent. Now 7-year follow-up, we already learned that at 3 years in this trial, the results were in favor of Zynes, but not statistically significant, with the premise, of course, that the acute and early events, which are higher in the BVS arm, would slightly convert on the long run because the stent simply dissolves over time, which would potentially lead to more results, more events in the metallic DES arm versus a absorbable platform. But that's something we have to see. This concept did not work in the final 5-year follow-up of Absorb 4, so I don't think in this trial will be much different, but let's see.
And what is your take then, Joost, on other bioresorbable scaffolds that are still under investigation? Are you still a believer in the paradigm of bioresorbable scaffolding?
Well, I mean, we have seen cases in which the devices in simple lesions actually worked excellent, with really beautiful, virtually healthy vessels after 3 to 5 years in patients with BVS. We have seen the same with the Magmaris, which is a magnesium device that dissolves quicker, but we also have seen the flip side with the BRS or Magmaris scaffolds that completely dismantled within 1 year and resulted in significant events with stent thrombosis and MI. So, I mean, if you look at the numbers of patients treated within the studies, which is thousands, showing clear inferiority of the technology, in at least with the BVS and Absorb, I mean, it's hard to believe that in its current form, these devices are ready for the future. The McMorris device, though, has shown very promising findings with a modified device that dismantles a little bit slower. And also that is something that was presented now by our colleague Cerato from Italy in a study focusing on the long-term results of McMorris in ACS. What I think is perhaps a bit more catchy and a bit more interesting at this stage is the results of the Biodopter randomized control trial. So you recall this trial, which will now be presented by Shigeru Saito, was randomizing 450 patients to Elixir versus Onyx and showed actually superior outcome with the Elixir Biodopter stent versus a Onyx stent. And that is quite interesting because most of the recent DS trials always showed non-inferiority. In this case, this trial showed favorable results at 2 years. Let's see if these results prevail at 3 years. And finally, Bong Ko will present some long-term findings of the Flavor trial, which, as you recall, is the Korean trial comparing IVUS to FFR-guided treatment, showing basically no difference between the two strategies at 1 year. But now the long-term results will be presented, which you could, let's say, predict or forecast in two directions. We will not do that for now, but stay tuned for the wrap-up.
Another trial that I'm looking forward to is a very pragmatic trial that also may shed some light on potential of invasive imaging, for instance, in influencing long-term outcomes. That study by Rohit Umrausingh.
Yeah, so this is an interesting one. The Perfect PSP trial is a trial that will enroll 248 patients that will be randomized to either a PSP strategy, so pre-dilatation, stenting and low pressure, and routine post-dilatation, versus a standardized approach allowing direct stenting in patients with generic, I think mostly stable coronary artery lesions. The concept of PSP obviously has been re-emphasized in the BRS era, in which optimal stent implantation appeared critical. Conversely, in these days, there is no consensus on whether you should do pre or post dilatation. It's typically left to the discretion of the operator in an approach that is typically angio-guided. However, in the most recent trials, we've seen that post-dilatation rates have increased from 50 to about 60 to 80% these days. So let's see, this trial will compare with the OCT endpoint whether stent results are better in those undergoing a PSP strategy as compared to a conventional approach with or without direct stenting.
I like it. Okay, let's go back to the structural space. One trial that we wanted to mention was the BRIDE post-approval study. Already published the 1 year data. This is a trial that included 511 patients with severe tricuspid regurgitation. They underwent tricuspid tear with the triclip. Good results at 1 year. As a matter of fact, more than 80% of the patients had residual TR of moderate or less, which is quite compelling. And the KCCQ, their quality of life, improved with, on average, 19 points. This is a big improvement. Now the question is the effect sustainable? And how complete are the echo follow-up data? Because you also want to see that these TR reductions are maintained over time. And obviously with Triluminate, the 2 year follow-up data that were presented at ACC, we already know that the effects, the clinical effects of TR reduction may not be so clear the first year, but they come up the second year. So let's see what the hospitalization rates are up to 2 years. I think this is an important study for the field coming from Europe. And then there is a parade of TTVR systems, so transcatheter tricuspid valve replacement systems. And I think the most important one comes from Thomas Modine, the Trinity trial, up to 150 patients treated with the Lux valve. It's all about safety and how good is this device in eliminating tricuspid regurgitation. But when we talk about TTVR, we also want to see what is the pacemaker rate, because there seems to be a correlation with more pacemakers, and what is the major bleeding incidence. That was one of the red flags, if you will, or at least an orange flag with prior prospective trials with TTVR. The interesting part of the Trinity trial with the Lux valve is that the Lux valve is inserted through a transjugular approach, not transfemoral, transjugular, and you don't even need a wire to introduce the system. So it's quite an intriguing concept that is different from the competition. The competition, well, there are multiple other TTVR systems. There is the VISTA trial that will be presented by our good friend Jan van der Heijden that deals with the VDYNE system. It's a transfemoral system. Unclear to me what Jan is going to present. Is it a full cohort of the VISTA trial? So look out for that. And then there are other systems like the Trisol that Isaac George is going to present, and also the dual tricuspid coaptation valve that Vino Turani will present. Studies in the field of mitral regurgitation. I think there is the EXPLORE study, the early feasibility of a posterior leaflet restoration device. There's a lot of experience in Tbilisi and also by our good friends in Brazil with the Polaris system. So let's see how effective and reproducible this procedure is. And another interesting technology is the AMENT TS pilot study that looks at the MRACE device, which is a closed D-shaped semi-rigid annuloplasty ring. It has a proprietary anchoring system. I want to know how effective is it, but also how complex is it to insert this thing? What is the procedure time? What are the success rates? All these things will hopefully be presented at PCR. With that, I think, Joost, a lot that we covered today. Again, this is not these very high-level randomized controlled trials that you will find at ACC, ESC, or other meetings, but very practical, and also it's about sharing and exchanging ideas and new techniques, technologies. I like it. I'm looking forward to Paris 2025, EuroPCR.
Me too. See you in Paris. Bye-bye.
Bye.